will start with a brief overview of where we are in terms of our pediatric treatment coverage, and then discuss some of the key elements of the WHO's 2013 treatment guidelines as they relate to children and adolescents. By the end of those comments, I think we will agree that greater global policy efforts are needed to close the gaps between our targets and the realities facing national programs. There are about 1/10 as many children with HIV as there are adults, but this does not mean that it has been any easier to advance pediatric treatment coverage. In fact, pediatric treatment coverage, shown in red, has continued to fall behind adult coverage rates, shown in purple. This drop, seen in recently released 2013 data, reflects the larger denominator of those now eligible for ART based on updated guidelines. Although more children are being put on treatment, shown in blue, the relative proportions are not keeping up with new infections and changing guidelines. And by the time we finally get these children on treatment, their infection has already progressed, causing damage to their developing immune systems and increasing morbidity. These data are from the IDEA Southern Africa regional cohort collaboration following over 30,000 children, showing that as the numbers of children starting ART increased over time, the rates of severe immune suppression and advanced clinical disease at treatment initiation did fall. But we are still talking about over 60% of children initiating treatment with low CD4 and high WHO stages. Besides catching the children in time to prevent disease progression, we have to anticipate how the changing epidemiology of new infant infections impacts our treatment strategies. At a plenary lecture in 2010, Elaine Abrams from Columbia ICAP warned that as PMTCT programs succeeded, we would have far fewer infected infants, but many more of them would have been infected in utero and/or have resistant virus. Simply put, increasing nevirapine use in PMTCT regimens is associated with increased resistance in infected infants. A study done in South Africa showed that 57% of infants with PMTCT antiretroviral exposure had resistance to NNRTIs, but 24% who had no documented or reported exposure to antiretrovirals also had NNRTI resistance at a median age of 10 months. This combination of issues, of knowing that our coverage is lower than in adults, that we catch children too late in their disease course, and that we are facing resistance following expansion of PMTCT, have all contributed to the guidelines we have today. And what are the current guidelines for children? I am a pediatrician, as is Dr. Mushavi, but I sort of assume that not everybody in the room is a pediatrician, so please bear with me as I go through some of these guidelines that some of you know very well. These are from the 2013 Consolidated Guidelines. For the first time, WHO advised that all children under 5 be started on ART, in addition to the clinical stage and CD4-driven recommendations, which changed the CD4 threshold from 350 to 500 for children over 5. The suggestion to treat all under 5 was in large part based on the programmatic need to simplify pediatric treatment to remove the potential barrier of needing a CD4 test in order to expand access to younger children. The threshold switch to 500 harmonizes the pediatric and adult guidelines, but we still face challenges in getting HIV-exposed infants diagnosed and finding the older survivors who fall through the cracks of our healthcare systems. These data remind us of how hard it has been to implement early infant diagnosis in low and middle income countries. The recommendation to treat all infants under 2 was made by WHO in 2010, and there has been some improvement in testing coverage in Eastern and Southern Africa since then. But the overall ability for countries to get infants tested in the first few months of life is still poor. 2013 reports are putting our testing coverage last year at 43%. Our mandate to test and link and treat is highlighted in many sessions in this conference and is captured best in what is considered the treatment cascade. But what about the pediatric treatment cascade? The reality is that the pediatric cascade is depressing. Given the confidence interval around the WHO UNAIDS 2013 estimate of 3.2 million children with HIV in low and middle income countries today, almost all of them are being considered eligible for ART, compared to 85% eligibility for adults. But 23% of these children are actually on ART, and we do not yet have global reporting data on pediatric viral suppression. The hope is that by simplifying treatment for younger children, we can achieve the better coverage that we all want to achieve. However, the question of what to start with has become more complicated. Because of the resistance issues presented earlier, first-line regimens for children under 3 include lopinavir, which is currently available in a liquid formulation for small children. For older children, the preferred regimen includes efavirenz, which has been shown in observational studies to result in better virologic suppression than nevirapine. And abacavir is recommended for both age strata, in part to avoid the emergence of thymidine analog mutations during first-line failure. But lopinavir liquid is harder to store, requires some level of refrigeration, tastes awful, and has been associated with reduced growth. Efforts are underway to obtain approval for a mini-tab sprinkles formulation of lopinavir by Cipla. There are pediatric and scored formulations of abacavir, but the drug is not widely available in some middle-income countries due to the relatively higher price compared to zidovudine, and has recently been shown in an observational study in Southern Africa to have lower viral suppression rates compared to D4T. We need more time to observe how these recommendations will be implemented and the impact of these drug choices within national programs. At the same time, it is good to be aware of what is coming in the future pipeline for pediatric first and second line. There are already discussions at the WHO about whether we can use the integrase inhibitor dolutegravir with the tenofovir prodrug TAF. Dolutegravir was approved for children 12 and older by the US FDA last August, and a global impact trial to study 6 to 12-year-olds is ongoing, including children in South Africa and Thailand. TAF is being studied in older children 12 to 18, and recruitment will include Uganda as well. For second line, ritonavir-boosted darunavir has been proposed as a future alternative to lopinavir. It is already approved for children over 3, and pediatric formulations are available. But the challenge here is the high price. These are some of the current costs in Asia and least developed countries for a year's worth of adult treatment. Pediatric drugs may be even more expensive unless we see successful advocacy for price reductions and generic formulations. Within our patient populations, those most in need of second-line access are our adolescents. Their WHO treatment recommendations are essentially the same as for adults. However, a perinatally infected versus a behaviorally infected adolescent can be quite different from each other and from adults. There are now over 2 million adolescents with HIV, and our adult HIV clinics seldom have youth-targeted approaches to promote adherence and retention. One reason why there has been such a limited focus on adolescent HIV in the past may be that few countries view adolescents as a separate population that should be counted. Out of the 193 UN countries reporting HIV surveillance data, only 30 of them report adolescent data, making it difficult to have a realistic sense of what the treatment coverage rates are. We do have reports from regional cohorts, some of which are encouraging, such as from Asia, with high rates of immune recovery and virologic suppression, and another from Zimbabwe, reporting that mortality among adolescents was similar to that of adults. But a recent WHO analysis that was cited last night in the opening ceremony by Dr. Sidibe showed that HIV is now the second leading cause of death among adolescents worldwide and the #1 cause of death of adolescents in Africa. We clearly need better estimates of adolescent survival and treatment coverage to help us to manage the growing adolescent epidemic. Perhaps the biggest implementation challenge for adolescents is long-term retention and care. In the perinatally infected, we face the need for lifelong adherence, which was echoed so poignantly in the video that was shown during the plenary session this morning. We also face the emergence of resistance and the need for disclosure, all before transitioning them to adult HIV care. The situation with the behaviorally infected is particularly concerning because they are stuck in the middle. Few pediatricians or adult providers are accustomed to managing these older adolescents who are not quite independent adults, but are also not going to feel comfortable in a clinic with young children. These and other reasons are why this group is less likely to be tested or to access and stay in care. And those in key populations like MSM, sex workers, and injection drug users are at even higher risk of poor clinical outcomes. The reasons for why adolescent HIV care is tougher than pediatric or adult care alone are illustrated by these comments on the right from a qualitative study done in Thailand. I won't read them now, I'll leave them to you to read, but a provider recognized that HIV exacerbates the usual problems of adolescents. And a policymaker shared that many local pediatric HIV organizations are simply not equipped or even disinterested in managing adolescents. So how are we going to close these gaps in treatment and in social support? There are some older and newer initiatives seeking to refocus the world's attention on children and adolescents. UNICEF, WHO, and the Elizabeth Glaser Pediatric AIDS Foundation released a document at the last DICASA meeting on what they call the double dividend. They argue that if we can align and share existing HIV and maternal child health platforms, we will increase our resources and impact in both areas. As you heard last night from Dr. Sidibe as well, UNAIDS is launching their 90-90-90 campaign, which relates to 90% of people knowing their status, being treated, and having virologic suppression. This program will eventually set global targets for children as they are doing for adults. But like for so many other things, the adults come first and the pediatric targets come after. And UNAIDS and WHO are working with global youth networks now on an initiative called No Adolescent Left Behind. And I will say that that paper for No Adolescent Left Behind was released before the global reports on No One Left Behind. The goal is to mobilize and train youth to advocate for their own treatment. Ultimately, our collective goal is to get more children on treatment. This is a cascade of where we were in 2013 in blue and what the WHO projections are for 2020 in red. The good news is that we expect far fewer children under 15 with HIV, in part because they will age up into adolescence and adulthood, but also because of large reductions in new infections due to PMTCT. But here on the far right is the 90-90 target of how many children should be on treatment. If you compare those numbers to where we are today, we have a long way to go to reach those targets between now and 2020. So in conclusion, I hope you will agree that the pediatric HIV population is growing up and its needs are shifting. We have guidelines that advise earlier treatment and have a stronger focus on adolescents. Yet we are still in urgent need of better early infant diagnostic testing at the beginning of life and strategies to link and retain adolescents in care as they reach the end of the pediatric spectrum. More efforts to prepare providers for adolescent management should be integrated into existing HIV care systems. And we hope that these recent policy initiatives will help us close the persistent pediatric adult treatment gap, especially as funding for HIV programs becomes more stretched. The children and adolescents in our countries have grown up their whole lives, waiting to see if the promise for an AIDS-free generation will actually come true. Thank you.